Hello and welcome to Cahuilla Health's Community Engagement Webinar. Today is Thursday, March 31st. My name is Deborah Volleson and I'm the Director of Community Engagement for Cahuilla Health. This is actually the last day of the first quarter of 2022. Wow. And I know, I'm kind of amazed that it's going by so quickly, but we're also right around the corner from April, and so white pants are now permissible to wear. Did you know that, Gary?
No, I always heard it had to be after Memorial Day.
No, Easter.
You could wear them between Memorial Day and Labor Day, something like that.
So you can't wear them after Labor Day, and you can't wear them before Easter.
Oh, okay.
So
I had the Labor Day part right, but not
that's
the
why I
Memorial
look
Day.
forward to April, not Easter, not
and
the Easter
why'd you turn to me to see if I've noticed?
Because I really want to know if you have any fashion sense.
I don't have any white pants. I have some white shorts, but not white pants.
Awesome. Well, right before we went live, we were all laughing because Gary did an opening with the Rawhide co-owner yesterday and was telling us a little bit about his baseball experience and how good he is. So
those weren't my words.
So we're really vying for him to do an opening pitch one game this season. But Gary, you asked me a question last week or 2 weeks ago about how many of these huddles that we've done.
Oh, yes.
And since 2020, we have done 70 community webinars.
Wow.
And this includes a couple of town halls, a couple of kid town halls, but we've done
amazing.
77 employee huddles.
And we're still going strong.
We're still going strong. So thank you for joining us. Gary, thank you for joining us. We're going to take some of the questions that have come in and try not to focus too much on COVID, but we're still all really curious about COVID.
Yeah, this is hopefully the last and final phase of COVID, so it wouldn't be appropriate not to talk about the end. Although I don't want to jinx us, because I don't know if this is the end, but that certainly is our hope.
Right.
Yeah.
Although, Fauci came out with another statement this week saying don't get too comfortable. Lockdowns could come again, and I was just like, turn it off. I'm kidding. All right, let's start with the numbers.
Yeah, well, the numbers certainly seem to indicate that COVID may in fact be on going down the end run here. As of this morning, we only had 12 COVID positive patients in the acute medical center. None of them were in the ICU. None of them are on a ventilator. Many, if not most of them, are definitely receiving oxygen support, but using a nasal cannula, something on a lower level. So that was excellent news. And then I know you're always curious about, okay, besides COVID, how's the rest of the hospital doing? And so there is a little bit of breathing room in the ICUs because I was up recognizing the ICU yesterday. The staff received our Pyramid Award, and so we got the chance to go up there. And they actually, on the wall, they have written how many days without a COVID patient. So that was really exciting because they definitely, throughout the pandemic, they took care of the sickest of the sick. And sadly, they were the ones that experienced the most deaths. And so it was good to see smiles back on their face. And they're actually feeling like they have a little bit of breathing room. So we actually had, as of this morning, 5 of our 21 beds on the medical ICU on the west side of the hospital were available, and on the east side of the hospital in the cardiac ICU, 6 of our 20 beds were available. So 11 critical care beds available for a new admission or a transfer to a higher level of care. But we do continue to be incredibly busy. As of this morning, we had 307 of our 332 adult beds, and you've heard me maybe reference 344. I used that number for a really long time because I was including the 12 beds that are on our pediatric unit that were being used as adult beds when the census was so intense. But since then, we've given all 12 back to the pediatric staff there, and they're delighted by that. So now when I talk about the adult beds, it includes everything except for that pediatric unit. So 332 beds, 307 of them were occupied this morning, but we also still had another 31 patients that were holding in the ED. A decision had been made to admit them, but they were waiting for the appropriate bed to be opened up for them. Or to have the bed, made available, the room cleaned and everything. So when you add those that were already in a bed and those that were holding in the ED waiting for a bed, we're at 102% capacity. So still very, very busy, still very, very full. And then the last number that I generally report to you is our employee vaccination rate. So when you're talking about just the initial vaccination, and virtually all of our employees received Pfizer here at the hospital, but those that got vaccinated later might have got Moderna as well. But both of them, you get 2 doses to be considered fully vaccinated. So I've been consistently reporting that we are more than 80% vaccinated for a number of months now. But the governor now requires of all healthcare workers that not only do you have to have that initial vaccination, but you also must have a booster shot. So a 3rd dose of either Pfizer or Moderna. And you had to have it by March 1st. And if you didn't get it, then you were no longer considered to be vaccinated. And so you either you either were mandated to get that booster, or you had to apply for a formal declination to be exempt from that booster, just like folks that didn't want to get the original vaccination, either for medical reasons or on religious belief reasons. So it appears that we have quite a few of our previously fully vaccinated employees that did not want to get that booster shot. So now, if we talk about who is fully vaccinated, meaning the original and the booster, we're now down to 60%. So that means people, again, that got fully vaccinated, they did not ask for a declination, but they didn't want to get the booster, so they did have to file a declination, and now they are subject to regular COVID testing, either once a week or twice a week, depending on which area of the hospital in which they work.
Okay, so how many of our patients with COVID have been vaccinated in comparison to those who have not?
Yeah, we no longer track that or try to identify that. We did during kind of the early stages, after the vaccine became available, which was in December of 2020. We did try to ask patients that were admitted for COVID if they had been vaccinated or not. We found it very challenging because a lot of times patients did not want to disclose that information, or they could not remember. We do, unfortunately, take care of a lot of patients with dementia and Alzheimer's, or they were not really in a responsive state. So we knew that our numbers weren't always that accurate, but we wanted to get a sense, and primarily it was for statistical, information purposes, that we were curious ourselves, but probably more importantly was we wanted to help you and our community really appreciate and understand how effective the vaccine was, because without a doubt, we were seeing 85–90% of those patients that were hospitalized with COVID were unvaccinated. So it really sent a strong message for vaccination in terms of keeping you out of the hospital. But then we really started realizing not only is it difficult to capture that information, and we didn't want to report out anything that was really inaccurate, it really didn't change the way we took care of patients. So if you're in the hospital with COVID, being vaccinated or unvaccinated really has no effect, does not alter or influence the treatment that you would receive. We would treat all patients that were COVID positive, that were primarily admitted to the hospital for COVID. Again, vaccinated or not, the treatment's going to be the same. So we stopped trying to determine it, and so no longer capture it.
Yeah, I think people use that information for different purposes anyways. If
Yeah.
you had it, it made you feel better knowing that if people were unvaccinated and, being hospitalized, you
Right.
felt a sense of relief,
Right,
like maybe
right.
that won't happen to me.
Yes.
But it is hard to track.
Yes,
It's kind of
yes.
like when people go in and you ask them to recall the medications they're taking or the vitamins that they're taking. Those of
Exactly.
us who take a large amount of vitamins, I stop after 3. And I'm like,
Yeah.
I know I take a bunch of
Right.
stuff, I just don't know what it is.
And I think you also, it's that, lab coat syndrome?
Yes,
That
the white
if-
coat,
White
yeah.
coat, that if you get admitted in the hospital, or you're at the doctor's office, all of a sudden amnesia creeps in and like, I can't remember
Why
that.
am I
and-
here?
Yeah.
So a question, what are the physician numbers, vaccination numbers?
I don't know that. Gosh, I will circle back
Because at
on
one
that
point
one.
they were up to like
They
90
were,
some
oh
percent,
yeah,
right? Mm-hmm.
they were in the mid-90s with the original vaccine. I don't know the answer to the physician question. Shoot, it's a
Okay.
great question.
We'll try to find that out.
Okay.
Okay, so now that our COVID-19 numbers have declined significantly, does this mean the hospital is no longer short-staffed?
Unfortunately, not even close.
Mm-hmm.
Yeah, so COVID's down, but as I mentioned earlier, we're at 102% occupancy today. So staffing is still a big challenge. We currently have about 500 full-time and part-time positions that are open. A little more than 200 of those are registered nurse positions. We still are making extensive use of travelers, but the state provided travelers that we've had, and again, we're incredibly appreciative of that. They started providing them to us back in September of last year and have continued to provide them all the way until today. So today is their last day. I think the state, is formally declaring the pandemic essentially over. And they were largely, they weren't providing these travelers to every hospital in California, only those that were really impacted with COVID. And so it makes sense with our number dropping down to 12 that, that they don't feel that there's no, a need any longer. So when those travelers all leave at the end of their shifts today and go back to their homes, we'll still have about 150 travelers that we're using. So down 500 employees, 200 RNs, still have 150 travelers. We're still paying the extra shift incentive bonuses in those areas throughout the organization that are still very short-staffed. Still paying overtime, but I'm happy to report that the usage of those extra shift incentive payments is declining. At the peak, we were spending more than $2 million per pay period in extra shift bonuses and overtime. I think we're down to a little over $100,000 per pay period now that we're spending in extra shift incentives. We only have 15 of our employees that are still out on a COVID leave of absence. Unfortunately, 7 of them have been out since 2020 or 2021, so it's highly unlikely that they're going to come back for whatever reason. So we only have 8 of our employees that contracted the virus in 2022, and so we expect that they will return as well. So a lot of positive signs that staffing is improving. Our turnover rate is starting to decline. So definitely going in the right direction, but it is going to take us some time to rebuild our workforce and get back to full employment.
Right, so you mentioned the empty positions, and I'm sure we do exit interviews, but are staff leaving, are they just leaving the healthcare industry altogether, or are they going to other healthcare facilities?
It's a myriad of reasons. There's no doubt about it that for these last 2 years across pretty much every industry across the country, including healthcare, we've seen a lot of employees leave. Some, a lot of early retirements, definitely. In healthcare in particular, I saw personally a lot of physicians that decided to retire sooner than they had originally planned. I'm certain that's the case with a number of our employees as well. So I think, leaving for retirement, leaving for work at home options that maybe, you can't work at home in this industry or in healthcare, but in this job I can. And that's really convenient for me and my family needs and everything. So definitely leaving for that reason. People just moving out of the area, leaving California, for whatever reason that might be. We've had a number of staff decide this is a great time to go back to school and get that extra degree or study in this field. So people have left the workforce for that. And then, other personal reasons, even employees that are fearful of contracting COVID or, any virus. Obviously, COVID is proven to be a very unique virus, and we've had more than 6 million people across the world have died of COVID. So understandably, a number of healthcare workers, I think across the country, 30,000 healthcare workers have permanently dropped out of the workforce. And a lot of them, might have had a compromised immune system themselves, or they lived with somebody that did, and they just didn't want to take that risk. So we also, unfortunately, saw a number of our nurses and other staff leave to go to work for the staffing agencies because they were offering, large increases in pay. Because the travel agencies were instituting large increases in the rates that they charged hospitals. In fact, Congress is investigating whether these travel agencies, I don't know if they colluded or they just instituted, price gouging practices. There's a bill that's been introduced in California that would require travel agencies to make a full disclosure of the breakdown of their fees to hospitals, so they'd have to show us exactly what the employee is being paid and how much the travel agency or traveler agency is retaining, but also would limit their price at a certain level. I think it's like 10% above their overhead costs. And obviously it's not helping us now, but should we ever have an experience like this again, it's intended to prevent that. So, and then people, we've also lost people that felt that the work was just too demanding here, and it has been. What our nurses have done over these last 2 years and worked to the point of exhaustion. And again, I have nothing but admiration and gratitude for them. But we've heard, nurses will leave that it's just, at this hospital, the acuity of the patients are so much less. It's just less demanding, less difficult, and sometimes leaving for less pay in exchange for having less difficulty. So
yeah, interesting. So when the newspaper reports COVID deaths, and we talked about this during the last webinar, but the question came in again. So the newspaper is now saying 95 deaths in 2 weeks,
Right.
And so this community member wants to know what COVID-related means. Is that they died of COVID or that they just had it at the time of their death?
Sure. Okay, so I'll be peeking at my notes on this one, given the answer. So there actually is a team at the Tulare County Public Health Department that reviews every possible or suspected or maybe COVID-related death. So. And I applaud them that they really want to make an accurate determination. Did this patient die because of COVID? And so this team looks at each and every one of those, and there definitely are nuances that are involved here, and they look primarily though at the cause of death that's stated on the death certificate. So if it says clearly that the patient died of COVID, hypoxia, and generally COVID is a debilitating respiratory disease that robs the body of oxygen-rich blood and then affects the organs, and unfortunately the patient finally succumbs to that lack of oxygen, despite all the attempts made to ventilate the patient and so forth. So they also look at medical records to help them make that determination. But they do look at also, was maybe COVID wasn't the primary cause of death, but it contributed to the death. That's also something they look at, and that obviously has a little bit more judgment involved. And like one of the examples that the county gave is, let's say somebody is admitted with terminal cancer, but they happen to also be COVID positive, because we test every inpatient, but they're admitted because of their cancer, and their death certificate says they passed away because of their cancer, but they had COVID. So the county will also look at, did they have other contributing factors? Like, did they also have COVID-induced pneumonia? So in that case, that it actually might be a COVID-related death because their COVID-induced pneumonia contributed to or accelerated their death. So in that case, they would probably count it as COVID-related. But if they didn't have pneumonia or any other, COVID contributing factors, then that death of cancer would not have been counted as a COVID death. So, and it's probably one of the reasons why, you read so much about virus or the infection rate declining, hospitalizations declining, but then we have this large number of COVID deaths that are reported, and it's weeks later. In fact, when the paper reported 95 deaths, they could have been COVID deaths that happened 2 months ago, but they didn't have enough evidence. Maybe they were waiting on the medical record or whatever it might be to make that final determination. So that's frustrating at times because it does lag along, and you can't really draw a correlation. But I think the county is doing a very good job in making certain that they're not counting a COVID death when that's not what the evidence suggests.
Mm-hmm. So it's the time it was processed, that's when it's counted.
Yes.
So
when this team has made their determination.
Okay.
Yeah.
Okay. So we also spoke 2 weeks ago. I believe Pfizer had just submitted their application for a 4th booster. So a community member is wanting to know, what is the status of that approval, and how will it affect us here at Cahuilla, and is it safe for people over 50?
So earlier this week, the U.S. Food and Drug Administration, the FDA, gave emergency use authorization to both Pfizer and Moderna to offer a second booster shot or a 4th dose. Important to remember that it's emergency use authorization. So they haven't formally approved the 3rd or 4th dose as a full FDA approved vaccine like they have for the flu. So it's still emergency use only. So right now, with respect to Cahuilla and our 5,100 employees and 700 providers, a second booster shot is voluntary only. It is not mandatory. Unlike the first booster shot, which is mandatory for healthcare workers, the second booster shot is not. So for now, it's remaining totally voluntary for us. However, that could change. Mm-hmm. So if the governor and the California Department of Public Health treats the second dose booster shot like they did the first booster shot, which became mandatory for us, they could declare for healthcare workers that the second booster shot is also mandatory. And if that's the case, then we will have no choice but to make it mandatory for all of our employees and our providers. However, we will continue to make available the declination process for our employees and providers. And again, we've taken kind of a more liberal approach to that. We don't interrogate the employee or the provider. We don't interview them. We don't make them provide us with evidence supporting, which largely has been a religious belief declination. They check the box, they sign it, and we respect that and we accept it. So that's what would happen with a second booster shot. And as I explained earlier, dropping from 80-something% full vaccination with just the original 2 shots down to 60% for fully vaccinated with the first booster shot, there's definitely some vaccine hesitancy. Folks were more comfortable with just the initial vaccine, which there was a lot less that was known, obviously. We were seeing a lot of infection and hospitalization and death, and people were understandably scared. A lot of people took the vaccine because of that. And now that they were vaccinated, there's a lot of question about how long does the immunity last, and I suspect though people that got the first booster shot will wait. I got the first booster shot. I don't know if I'm going to take the second.
Right.
If it becomes mandatory for me, I will, most likely. I'm not going to submit a religious belief declination. But I'll have to face that, as will all of our employees. As far as safety, I really got to look to the FDA. They obviously feel it is safe enough, to grant emergency use authorization. So they're very careful about, they've been looking at this second dose request for a very long time and studying it, and they once again believe that the benefits outweigh the risks.
Why haven't they fully approved the first booster? Why is it still only emergency use?
I don't know. My recollection, I could be wrong, is that Pfizer did gain full FDA approval for the initial vaccine.
Okay, the first 2 doses.
The first 2 doses. And that took a long time because it was emergency use authorized only as well. But I believe they finally got their full authorization. But then the first booster was emergency use only. And what I read this morning is that the FDA revised or expanded its emergency use authorization to these 2 drug companies to allow this second dose. So it really suggested that the first dose is also EAU and not fully approved yet.
So a chat, when will COEA be offering the second booster, and will we be able to cross boost if we choose to do so?
Yeah, it's a great question. And I think I learned something when this was asked the first time when COEA. So first, obviously the FDA just approved the second booster shot. So it will have to go through the process at COEA. It has to go through what we call our P&T committee, which stands for Pharmaceuticals and Therapeutics. So first, use of Pfizer or Moderna as a second booster will have to go through that committee and will have to formally be put on our drug formulary and be allowed to be administered at COEA Health facilities. So that could take a couple weeks, generally 2-3 weeks. I'm certain that James McNulty and the committee are already now evaluating that based on this news this week. But if they do approve it, we have both Moderna and Pfizer at various sites, urgent care centers and clinics, and so we'd make that available to the public. And as far as the matching and cross-matching, certainly the first booster, it actually was encouraged to cross. In fact, I had Pfizer as the original, and I got Moderna as my booster. So I haven't read anything but I suspect that given that, they're going to allow the mix and match on the second booster.
Okay. We were watching a lot of the reports and studies that were coming from them because they had such a large population that they were vaccinating. Because I thought I read something that they were boosting almost every few months. I
definitely read that, are we tracking Israel? So As a hospital, we're not. We don't do any research or, ourselves. Although I could talk about Dr. Pantera's research project. But certainly the country and our scientists and our government and the CDC, and they're all watching Israel very closely. Because Israel has really been kind of out in front with a lot of their testing, and so they have for some time been giving multiple booster shots. I don't know if they're going beyond a second booster, but I think that's why we watch them so carefully. I think I even made reference to a couple studies that they conducted just recently. So I don't know what's going on there. I know that with respect to both the Moderna and the Pfizer vaccine, that it's only been authorized in individuals, adults only, that are 50 years old or higher, or under 50 years old, but you have a certain type of compromised immune system, and there's specific criteria that you fall into. So it's only those folks that are eligible right now in the United States to take that second booster shot. I'm certain that we'll continue to see more news about the age group dropping. Will it go all the way down to 12? Will it be offered to children? We'll be seeing that rolling out in the coming months. And you have to be at least 4 months out from your first booster shot to get your second, and that's both with Pfizer and Moderna.
Okay, we have the answer. That's the physician vaccination. Thank you, Kelsey.
Yes. So 96% for those that were originally vaccinated, and that's dropped down to 92% for those that also have been boosted. Boosted, is that?
Yeah, that makes sense.
Isn't that when you get robbed or something?
That's a term.
You get boosted, or I don't know if that's, yeah. So 92% of our medical staff has got all three shots. So definitely a higher use than our own employees.
Awesome. Okay, so a few months ago, Gary, we took the months of October and November, and we met with a lot of stakeholder groups about the master facility plan. Probably a lot of people on this call participated in one of those groups. So the question came in, where are we at with the master facility planning process?
Sure. Yeah, we're still very active in that process. So myself and Mark Mertz, who's our Vice President and Chief Strategy Officer, Kevin Morrison, our Director of Facilities. The three of us continue to work very, very closely with RBB architects. We still are singularly focused on a single tower that would be built on our downtown campus immediately adjacent to the Asequia wing. But one of the things that we're kind of evaluating right now, we think makes a lot of sense, is you may heard of us, we talked about a 9-story tower that would have 240 beds in it, as well as a new pharmacy, new dietary, new cafeteria, and a basement. But one of the things we've been contemplating is a lot of our operating rooms where we do surgery, many of those operating rooms are located in the Mineral King wing. So we do have operating rooms in the Asequia wing and in the East Tower on the east side of the hospital, but a lot of our ORs are old and they're in that 1969 Mineral King wing building. So we're thinking about a floor that would be dedicated to surgery and recovery, and actually looking at the second floor, which then you say, okay, it's going to be a 10-story tower. Not necessarily. In fact, we're thinking that it could be even shorter than 9 stories. And what we're contemplating is actually increasing the size of the footprint. So in the 9-story design, each floor has 30 beds on it. But we could expand the size of the width of the building, that we would put 40 beds on each of the floors and still be able to build that second floor surgical recovery floor. Still have a new dietary and cafeteria and pharmacy. Still have a new basement, but it would also allow us to literally consolidate all of our surgical suites into a common area. So we would still have the cardiac ORs, the C-section ORs that are in the Asequia wing, but they're on that second floor. And so if the Asequia wing is actually going to be connected to this new tower and we put that on the second floor, it just, brings everything together. It would allow us to be more efficient, more likely, more cost effective to do it. So Mark and Kevin are working with RBB right now to, evaluate adding this addition to it. And initially it might, appear that it's going to cost more, but they're trying to see are there ways to offset that cost by having a shorter building, because the taller you go, the more expensive it is. The deeper you go with your foundation. And so if we make it, let's say, squattier, I'm sure there's an engineering term or architectural term that's better, but yeah, could we possibly keep the cost the same and get a whole floor dedicated to the surgery and recovery? We'll probably have those final cost estimates available in May, and once we have that, then we're working on how we're going to fund it. And once we feel comfortable with that, we know that we're going to have to go to the community and ask them to support a bond measure. So we'll determine the size of that and its duration and the tax rates at different levels throughout the life of the bonds. And so once we have all that information in hand, then we'll be ready to go back on the road and start meeting with folks and sharing all that information.
Yeah. So is there word on the streets, SB 1953, is it getting pushed back? Are they still holding firm on the 2030 date? Anything?
Yeah, I'm not hearing a whole lot lately, other than it is the California Hospital Association's #1 priority right now, is to get SB 1953 repealed and replaced with what they call a modernization legislation. So that they're looking to extend the 2030 date to achieve seismic compliance, but also changing what seismic compliance looks like. Because right now there are 5 categories of structural performance categories. 1 is the worst, 5 is the best. And so right now, by law, by January 1, 2030, all the buildings in which you provide acute inpatient care must be rated SBC 3 or higher. Our Mineral King Wing is an SBC 2. So this new legislation that's being pushed would actually drop that SBC 3 requirement down to SBC 2. So you have to be SBC 2 or higher by 2030, although they're trying to add maybe 7 to 10 years to that 2030, because there are actually a lot of hospital buildings across California that aren't SBC 2 yet. And so they want to give them more time to meet that. Our big issue, though, is the only reason why we were given SBC 2 certification, because we should be SBC 1, because our hospital was built before 1973, and you automatically got categorized as SBC 1 if you were built before 1973. Ours was built in 1969. Unless you had a seismic risk analysis done by FEMA called Hazard US, where they deemed you to be of such low seismic risk, your distance from a major fault line, the geology of your soil and stuff, then you could use that certification by HAZUS, or that information, to ask OSHPD to increase you from SBC 1 to SBC 2. And that's what happened. We got a very favorable HAZUS report. We submitted that to OSHPD. They came back and said that we are now considered an SBC 2 hospital. Unfortunately, what I learned not too long ago is that in CHA's negotiations with OSHPD, that was one of the concessions that they made, is while they want OSHPD to consider SBC 2 and higher to be seismically compliant, you have to be SBC 2 without your HAZUS consideration. And we don't meet that. So that's very disconcerting for us. And so we're going to continue to negotiate, work with our local legislators. It's important for us, because I think it really affects our timing. I think we all agree that we need to modernize Cahuilla. We need to move forward with this project. It's really important to our community and our future communities. And nobody likes being a patient in that small triangle room. But to be able to build this new tower and do it in a cost-effective and timely fashion, we need to be able to continue to use the Mineral King Wing for a longer period of time. And so achieving SBC 2 and allowing us to do that is an important part of the whole master facility solution. So we're going to keep working on it. We brought it to everyone's attention. CHA is fully aware of that, how that compromise affected us.
I remember back when 2030 seemed like it was a long way out.
Yes, it
Yeah,
did.
it's right around the corner.
8 years.
Yeah. And so when do you think they'll make ruling on that legislation?
Probably not to the fall. And I will tell you that there's tremendous pressure by the trade unions that see hundreds of billions of dollars in new construction and new union jobs and expanded union jobs. And so, as you might expect, they're very opposed to this legislation. In fact, they don't even want to see the timeline extended. They want to keep it as is and keep the deadline as 2030. And unfortunately, I don't feel that OSHPD is really in our corner as well. OSHPD is not supportive of dropping down the qualification to SBC 2. They want it kept at SBC 3 or higher. Now, unfortunately, they don't make the decisions. They're made by the legislature. And that's been one of the silver linings of this pandemic, is it's laid bare the financial struggles of hospitals up and down California. There is no funding. There's no state or federal funding to come into compliance with SB 1953, and it's estimated that it will cost something like $240 billion to come into compliance. 40% of California hospitals do not meet the SBC 3 or higher. So something has to change. And I think the legislators realize that. It's just, what is something going to look like?
Right. Okay, so we're also in the process of changing our district boundaries. And so we've had several public meetings. Where are we at now on that?
Yeah, so we're coming to the finish line. The board has held a number of public sessions, and they've been highly productive, and I commend our public that's been participating along with us. Has given us great input and perspective and ideas. And so on April 13th at 5:30 p.m. Out at Sequoia Regional Cancer Center in the Maynard Fott conference room, the board will meet for the final time on the redistricting or rezoning plan. And so at that meeting, they will complete their final study and analysis of 3 maps that they are focused on right now. One of the maps was submitted by a member of the community, and 2 of the maps were submitted by our consultant. We actually had more than that, many more maps than that, but the board has kind of narrowed it down to those 3. And so they will make their final decision, and they will vote that evening as to which map they will adopt.
Okay, and then it just becomes it?
Yeah, I don't know if it's effective immediately.
Okay. So nobody has to approve that, pass that?
No.
Okay.
This board has the final say.
Okay.
Obviously they have certain conditions that they have to achieve And so all of their maps do that. So they've met all those requirements. So now it's really up to them.
Okay, well, cool.
Yeah.
So the last thing is not a question, but a comment. Somebody wanted me to tell you that the new signage looks great on the 5-story building.
Oh, the support
on
services building?
Menlo King.
Yeah,
Yes.
yeah, thank you.
Yeah.
We've gotten lots of compliments about that. And it's certainly from a wayfinding standpoint, if you're driving on 198, you don't really see the Kauai Health Medical Center signs, that are on the Sequoia wing or the front of the Mineral King wing. So this definitely makes us much more visible off the highway, and just has a very classy look to it.
Yeah.
And so thank you for that feedback. We
Yeah.
appreciate
And
it.
all of the signage, as it's changed, it looks clean, colorful, very visible. So
Yes.
that was marketing. Good
Awesome
job,
job.
marketing.
Absolutely.
Yeah. All right, Gary. Well, we have a few minutes, but I say
Oh,
we go
okay.
ahead and
Yeah, we'll
Close
wrap
it out.
up this last day of March, as you said, which is just hard to believe that the first quarter has already flown by. And while we certainly love these spring-like days, it's kind of crunch time here at the hospital. Not only are we really busy from just a patient standpoint, but we're now in the midst of budget season. Our fiscal year end is June 30th, so all of our leaders in the hospital are trying to forecast with some sense of accuracy, which is really, really difficult in these days and times. But trying to establish the budget that will go into effect on July 1 of 2022. So we're an $800 million a year organization with an annual capital budget of somewhere in the neighborhood of 15 million. So a lot of work going on right now. So it makes the days go by fast, and maybe that's why already it's March 31st. We know what tomorrow is. April Fool's Day. So before we got on camera here, our ladies here in the production studio were having a little fun with Daniel Baker over here, and because I came into the room and they were just howling. So they got an early start on April Fool's Day, but
And you're coming back to the studio tomorrow, Gary, on April Fool's Day.
I know
so
I am.
you might be a little
I am,
nervous.
but I was going to tell you that not only is it April Fool's Day, but tomorrow will be my 30-year anniversary with the Kauai Health organization. So why I started on April Fool's Day, I have no idea. It wasn't purposeful by any means, but it just happened to be probably on a Monday and perfect day to start. So, and you talk about time flying by. I just cannot believe it's been 30 years. And I remember my first day here like it was yesterday. So excited about that. And just excited that you come back every couple weeks with us. And again, we appreciate your consistent and constant engagement with us. Thank you for the great questions that you're always asking, and keep them coming. And we'll be back in a couple weeks. And in the meantime, stay safe. But enjoy our weather and enjoy each other. So we'll see you in a couple weeks. Bye-bye.